So I see this article and I'm like, one hand I hear like MDMA, I'm like, that's a party drug that looks like criminals and drugs and cartels and whatever, right? And then the other hand, PTSD is like, isn't that like government and soldiers? And like, it's just like the gap it created in my mind that how different these two are. And now I'm seeing them in the title together.
Welcome to Intonicated, a podcast about psychedelics, learning, and well-being. Intonicated is an adjective that describes a heightened, expansive, and health-affirming state of consciousness marked by clarity, vitality, and integration, in which a person feels inwardly attuned and stretched towards deeper awareness, emotional resonance, or spiritual growth. I'm your host, Ken Tupper. Please be sure to like or subscribe. Okay, hello, Pedram. Thank you for joining Intonicated. I wonder if you can just start off by introducing yourself.
Sure. Hi, Ken. Thanks for having me. My name is Pedram Dara, and how do I introduce myself? I'm currently the founder and director of a patient-led initiative called Psychedelic Lived Experiences, and I've been sort of working professionally in this field since 2018, early 2019, when I participated in a clinical trial of MDMA-assisted psychotherapy for PTSD here in Canada. Back then it was a phase 2 trial for the therapist to then be able to go work on phase 3. So essentially I was the very first person in Canada outside of BC to receive a legal psychedelic as part of a clinical trial back in 2018.
Oh, great. Okay, thank you. Can you tell us about when you first heard about psychedelics? I guess first encountered the idea of, and then how you first encountered the opportunity to use a psychedelic. You said it was in a clinical trial.
Yeah, I'm very naive in that sense. I would say I didn't grow up in the West. I was not even exposed to psychedelic culture at all, I would say.
Where did you grow up?
So I grew up in Iran, and back in Iran or anywhere in the Middle East, perhaps, like, especially when I was growing up, I'm a kid of the 80s, right? It's like psychedelics were not a thing, right? Like you speak of drugs and there's the hashish and opium, and those are like the drugs. When you think of drugs, you'd rarely think of this whole class of other drugs we call psychedelics in the West, right? So for me, I was exposed to it after coming to Canada. I moved here as a refugee back in early 2004. And so I didn't learn anything about it. So for me, it was always like I just knew about, like, obviously there are drugs people take in clubs or festivals, but I never went to any of those. I'm not I'd never experienced anything like that. Imagine I went to a club first time in my life. Maybe I was like 22 or 23 to even have a club experience, So I come from a very different background, and I had to, like, so for me, when I learned about psychedelics, it was almost the very first time that I was also learning about mental health. Generally, also didn't have mental health education, right? So I kind of was exposed to both at the same time. Both the problem and the solution were presented to me at the very same time. And so for me, in a way, the more I learned about psychedelics, it has always been more on the therapeutic side of psychedelics, whereas, like the recreational stuff was never there for me compared to some peers that I meet in the field now.
Okay, and then how did you first encounter the opportunity to participate in a clinical trial with, I think you
So
said it was MDMA?
yeah, exactly. So late in 2018, or yeah, fall of 2018 is sort of where I would say was like, yeah, I would say 2018 was the worst year of my PTSD symptoms. I would say I had just become a father. My daughter was less than 2 years old. And up until that moment, like, I had dealt with my mental health issues the ways other people do, right? Like put my focus on work, making money, fame, whatever you want to call it, like anything else that would make you feel better, right? Shopping, buying stuff, watching things, right? And I thought that's how you deal with things. I never, like I said, had that mental health education of like really looking into like, why am I even feeling this way? So sort of when I became a father, the loss of sleep, the sort of like new change of identity, I would say really push things out of the way. In a way, I'm grateful that happened. At times I'm like, if I would have not become a father, I wonder if I would have ever even get to this place at all. So in a way, that challenge, as much as I regret not being present in those first 2 years of my daughter's life, which I will never get back. But at the same time, that allowed me to actually take action. Like when everything came to the surface, that I was like, okay, I really need to do something about it. So one of the days that I had massive rage episode, and I would just get really mad at like small stuff, right? Like it was never really big stuff. It was always like very small stuff, but like having very out of proportion reactions to those, right? So whether I was like very hyperactive, I would go into like rage episodes internally or externally, or I would just shut down and dissociate. So there was really no like mid window for me. It was very black and white. So that day, like my daughter and my wife left the house and I stayed home in my own misery and I just grabbed the phone. It's just habitual thing of distracting myself right now. I couldn't sit with the pain of what I had just caused. And scrolling the phone and I'm just like suddenly an article pops up talking about using MDMA therapy for PTSD. This is like again fall of 2018. This is before Michael Pollan. This is like nobody was talking about psychedelics in 2018. When I say nobody, I mean like nobody outside of the academic and regular conferences, in regular life stuff, it was not a thing.
Yeah.
So I suddenly see this article and I'm like, on one hand, I hear like MDMA. I'm like, that's a party drug that looks like criminals and drugs and cartels and whatever, right? And then the other hand, PTSD is like, isn't that like government and soldiers? And like, it's just like the gap it created in my mind that how different these two topics are from each other. And now I'm seeing them in the title together. It's like, I was like, okay, click on it. I'm reading about it. And I can never find that article because I wish I would have remembered actually who published it. And then that article was talking about PTSD. Right? I had like this long list of symptoms of PTSD, and that's the first time that I'm reading the list. I'm like, wow, I got that, I got that, I got that. That was like my aha moment to even realize
you hadn't been diagnosed with PTSD at that
nope.
point.
No,
Oh,
no.
okay.
This is what I mean because I lacked the mental health education, right? So I didn't deal with it. I never seek help professionally the way
So I see what you mean then. Literally, the problem and the solution came to you
presented
simultaneously.
themselves at the same time. Exactly, right? So I'm a bit of a different case in that ways. Many people like tried SSRIs for many years. They tried talk therapy for many years, and then they learn about psychedelics. Whereas for me, it was like both of them at the same time. And so once I just had like, oh, maybe this is what I'm dealing with. So it was more learning about PTSD parts that actually became interesting for me than learning about the MDMA part. And then, and the next thing I found out there was clinical trials happening around this. I mean, US government website where I had the list of all the trials that were happening. And I was like, oh, I'm just randomly, I click on one of the trials and there was a site in Montreal. So I just saw the phone number of area code of Montreal and that's where I was living. I was like, what are the odds? It was like the one site in all of Canada back then and happened to be where I was living. And they were looking for someone in that very exact same window. Like I would have read that article 2 months later, 2 months prior, this would have not all happened. It was like exactly the same window when they were recruiting. Right. So then that's it. And I was like, just next thing I just called. And then from there, obviously the rest is history. But it was like a good 2 months process just from me learning about it until I was actually officially enrolled in the study.
Well, and not just, that you called, that you were eligible, that it all worked out, that you were able to, and you were one of the earliest patients in their
I was their
cohort.
number one. I was their number one. Like I said, so there was a trial in BC, in Vancouver, which I think had shut down around maybe 2015, 2016-ish. So there was nothing else happening in Canada, basically, after what happened in BC. And then this site in Montreal was the first time bringing it back to Canada, in a different province, of course.
So after you had that, how many sessions did you have
So that's
with
3 sessions, 3 dosing sessions, and then you get like 3 psychotherapy sessions, obviously at first for sort of like prep, and then you get 3 integration sessions after each dosing session.
So I'm interested in the experience you had, but maybe you can tell us about how you came to the idea of the Psychedelic Lived Experiences organization subsequent to your finishing the trial.
Yeah, so it only is making sense to me now, honestly, which is why, as I was just thinking about coming to this conversation, I just looked at my hair. I was like, wow, there's a lot of gray hair there that I didn't have 6 years ago. Like if you look at my footage from when I got to the trial, like it was all black hair, right? But that's in a way, my culture, we actually have a saying. We say like when someone wants to show themselves that I've been through shit, you're like, I didn't get my hair white with like baking flour. I'm just paraphrasing, but something like that. I mean, it's like, I've seen some real shit. The white you see here comes from like being through this stuff. And so now I think things a lot make sense to me because I'm like, okay, it's been 6 years now, right? So like now I can actually look back and be like, why did that make sense to me? And only recently, it's been a few months that I fully understood actually what happened because my background before entering into psychedelic world was that I was a product guy. was working in tech and doing product management. Before that, I worked in media, doing production. So I've been always a producer, like building stuff, right? So whether it's like a movie or a TV series or software, it's always been like figuring out what people want and then building a solution, whether it's an entertaining solution or, like I said, tech solution, but it's always been around first figuring out what people want and then building something that fills a gap. Then I go to, and in that world, I have to say, in that world, innovation is completely run by what they call users, right? It's interesting because the only two industries that they call their customers users are tech companies and drug dealers. But in a way, it's the same way, right? If you watch The Social Dilemma, the Netflix series, it talks about that, right? So obviously, they have bad intent around why they use user to drive innovation because they want you to stay on the platform, right? And that's how they make more money. However, if you put that aside, just the approach to it is the best approach. In tech, essentially, the user is the boss. So you as like you could have the fanciest education you want to get. You could be a PhD from Harvard in like computer science, and nobody cares what you think. If I can show up as a product manager and prove to you that people care about certain colors or certain shape or certain way of interacting with the product, well, man, your education means nothing, right? So I could literally come in and convince and build products and features that will be used because the users told us, right? So like YouTube is a great example of that. They're constantly asking people how to make the product work for them, right? So then I go to psychedelics as a user, you could say now I'm a user in a clinical trial. And I go through this process and I'm just realizing, wow, like here, user is not the boss at all. If anything, user has no voice. Like I just felt such a contrast from the world I was used to, where the users and the end users' voice was the only thing that mattered. I come to healthcare and I'm like, I have no voice. Like no one even cares what my opinion is. Like how should things be better, right? And I'm a problem solver. I'm constantly looking at the world, ways to like improve it. Even in my own mind, I'm just like always like thinking of how I could improve it. Even if I never build that product, I'm always like, oh, I can see how that could be solved, right? So I'm constantly doing that. And then I go through this process and I'm like, wow, like nobody even asks me. Sometimes I buy coffee and somebody asks, how was the experience with the barista? How is it that I can like rate an Uber driver? How is it that I go to an Airbnb and I can have a comment and the person can improve their Airbnb and then the next guest can have a better experience? But then in healthcare, none of it. Like it was like, so going through the process, I was like, I'm just the only one. And then I met more people. That's why I said that now it's been 6 years because I met many other people through this experience, other people who felt like they went through the experience. Because there's two groups of people who go through the psychedelic experiences. The ones that have the experience and they move on with their lives. That's probably the vast majority. Then there's like a small minority of us, people who like go through the experience, they notice something and they're like, I want to kind of stay back and see if I can help with that. So I fall in that category. And yet I saw there was no mechanism to actually collect feedback. There was no mechanism to actually even care. And if anything, users' voice in healthcare, mental health care is meant not to be trusted at all because we have deep, dark history around psychiatry where like people with schizophrenia voices were not trusted. Eventually, people with borderlines voices were not trusted. Eventually, people with, like multiple disorder were not trusted. And then somehow, without any evidence, there was this unspoken thing, this blanket thing that obviously in psychiatry, they just feel like, well, patients' voices cannot be trusted. Like these people are obviously not well. How can they have a say? And here I am the doctor and I'm the therapist. I did 10, 15 years of a study, so I know everything. Right. So I'm going to tell you how it should be done. Right. And that's the farthest from true, actually, at least within psychedelics with all these like subjective experiences that some of these practitioners themselves may lack. So all of that led into me figuring out what's the best thing I could do was to just bring more attention. So what we call lived experience here is really user experience in tech. Like this is, you could call it medical user experience, but that's irrelevant. So I was going to say it only lately made sense to me how my background in software and product management is like allowing me to now do this, but I didn't even realize that was happening.
I really appreciate the observation about the word user being only applied to software and it's actually illicit drugs, right? So it's
Yeah.
That's really astute observation. So I wanted to ask you about the tension between patient-centered care and provider-centered care or system-centered care, which you were just alluding to. Certainly, the idea of patient-centered care has gotten a lot of traction in lots of other areas of healthcare, like cardiology or diabetes, like other areas. There's lots of active involvement of patients or recognition that patient experience is important. Mental health been more challenging. I'd say it's even more challenging probably in the area of addictions, especially when there's opportunity for medication-assisted treatment, such as methadone for opioid use disorder, where the patient's desires may not be accounted for at all by the clinician. So I'm just wondering if you can speak further about that. And I guess the other piece is that providers in the area of psychedelic medicine often do have their own experiences. They may not talk about it either to their patients or in published literature, that sort of thing. I was wondering if you can comment, and do you think providers should have their own experiences with psychedelics
Yeah,
in psychedelic therapy?
thanks for bringing that up. And there's few ways to look at that. So first of all, the whole like patient-centered care, it's a slogan. Like it's it's similar to like people that are like, oh yeah, we have people, we live the experience. It's a lot of tokenizing. It's a lot of like just saying we do, but nobody really knows what it means, right? Like show me with action, not with words. Like you go read some organization's website, they say patient-centered care, and then you look at their board, not one patient on the board.
Mm.
So, like to this day, show me a single organization, let's say in psychedelics, that has an advisory board or a board of directors, and there is even one. Like I was about to say, if there's a balance between clinical and scientific versus lived experience, there isn't even one. Like it's just those people don't even make it to those rooms. So it's so easy to go out there and say, oh yeah, we do patient-centered care, but then it's still the doctors and therapists and researchers making all the decisions.
Yeah. Yeah.
Right. So to them, it's like, yeah, we are listening and all that. Okay, sure. But like, but show me your method. Like, how are you listening and who is in the room? Like, do you have those people in your care team? Right. Like, when you're making the decisions, are they representative? Like, so it's one of those things that I've noticed it's just so easy to say. And unless you have some sort of like a vegan or kosher label where you know, okay, the product is that, otherwise anyone can say, right? It's like if it's so easy to make a product today and be like, yeah, we are vegan, but if nobody's actually checking is this really vegan or not, then anyone can say that. So patient centered is kind of like that. It's like a thing people say, but no one really knows what it means. On the side of live the experience of the practitioners, that's actually very interesting because when I did the summit, so I spoke to 27 patients and trial participants, but also spoke to 27 clinicians and researchers, right? And it was very interesting to see how, first of all, the word lived experience means different things to different people, including the professionals, right? So, like, you would think, oh, here's two doctors or here's two therapists, and you would think they both have the same understanding, and they don't. So, I want to unpack what that could mean, right? Because a lot of them, like you said, have these personal experiences with psychedelics. Perhaps is what got them interested in the field, why they decided to be like, ooh, I see something and I'm going to go research more on this or I'm going to dedicate my career on that. And then, however, you doing psychedelics as part of a retreat somewhere or alone at home or at a festival has absolutely nothing to do with somebody receiving psychedelics as a treatment for mental health condition. Like until people can actually really see those buckets as different experiences.
It's not psychedelic lived experience, it's psychedelic patient lived experience that's really the crucial piece that you're trying to
Exactly,
bring to light.
right?
Yeah.
Unless, and I have in the summit, I have at least three therapists, or at least let's say psychologists or healthcare professionals, three or four, actually, four, I think, that have had that experience. I call those professionals with lived experience, right? But they don't come out. Like these four are some of the only four I know. Like you said, they have a license to worry about. There's the stigma around it. But then some of them have gone as part of training programs, have had that experiential training. That's the closest thing to it. A couple of them actually no, they also had their own mental health challenges and they actually went and either participated in a trial or received the legal clinical treatment. Well, that is different. Like if you're a nurse and you have PTSD from being a nurse, and then you went and you received immunotherapy for PTSD, that is the lived experience I'm talking about. Not that you're a nurse and you did psychedelics in a festival, you saw something, and then you're like, oh, now I want to go work in there. So there's the difference between those experiences, right? And this becomes even more crucial when you think of a clinical trial
Mm.
versus even like a ketamine clinic, for example, right? Because even those experiences are different, right? So like if you go and receive ketamine as part of a clinical trial, it has nothing to do with you receiving ketamine as part of a ketamine clinic. Like those experiences are vastly different from each other, right? So this is why a lot of practitioners, when they say, well, I also have my own lived experience, so also I was like, okay, great, but that's enough just to give you passion around this work, but you still know nothing about going through a clinical trial process. You still know nothing about being treatment resistant with certain health conditions, right? That experience you don't have, right? So unless you incorporate people who have those experiences to sort of like deepen your understanding, you're always going to have a limited picture.
Can you speak more to that treatment resistance? So you're talking about people who have signed up to be part of a clinical trial, but they don't respond to the medication as hoped. And you've talked to folks like that, and I know some of your work. Can you speak more to the sort of unique circumstances that go along with that?
Yeah, because a lot of people, when they come to psychedelics, it's sort of the last thing for them. Like I said, my story is different. For me, it was the first thing, but I recognize how different that is from others. For many people, almost vast majority of people I interviewed, they always say like, oh yeah, like first I tried it SSRIs for a while. I tried it multiple SSRIs, then I tried talk therapy, then I did EMDR, and and then eventually they come to psychedelics. They're sort of like, well, this better work, right? Which, when you even look at the cases of harm or when things went really wrong, now I know some of those people individually myself who have come out and spoken negatively about psychedelics and these experiences because I know them personally. And I know that they have told me at least that this was their last thing. They're like, this better work or I'm done with my life. Well, so when you come with that kind of expectation to any sort of experience, like I wonder what you're gonna get from that experience, right? So like if you're coming to like this better work or not, so because why? Because I've already tried many different things, right? So like live the experience of somebody having depression for 10 years and tried 10 different ways to deal with that depression, and then eventually they learn about psychedelics is very different than even like let's say a practitioner going through a psychedelic experiential training and even having their own, let's say, MDMA experience or ketamine experience, right? But you may still have the experience of like, okay, I know how it feels in my body, but you still don't know how it feels to be having the label of treatment resistant or having these sort of like labels of non-responders and like just feeling like if there's something wrong with you, as if like the treatments are working for others and you're just somehow resisting, as if there's something wrong with the individual. Right? So
Mm-hmm.
like the shame you might carry around that, those are also lived experiences, right? With or without psychedelics, that many practitioners just don't have themselves or not
Yeah.
willing about it.
So when folks come out with that non-responder, or worse, I guess, an adverse event or some kind of negative experience that happened that maybe leaves them feeling worse than they went in, how do we talk about that without, you know, slipping back into kind of stigma and fear mongering that certainly this whole field has come out of, like over the last 30, 40 years, where there was very little research even possible, in part because of that kind of stigma. So how do we square that circle from your perspective?
Yeah, I mean, this is something I think about on a daily basis, right? Because even just taking the last 6 years that I've been involved in the field, I already saw it, like I came out of the study, Michael Pollan book came out, Netflix series came out. So I experienced this whole like psychedelic rush and renaissance, whatever you're gonna call it. It just suddenly became like a big thing. And everybody was so like, and I was like, oh, I'm sort of glad that I got the thing that now everybody's talking about, right? And then 2 3 years later, then sort of I saw the pendulum swing to the other side. Now it's like people talking about harms and and challenging experiences, and like I mean, and obviously some of those even you could say really influenced the FDA's decisions around approval of MDMA, right? So I sort of like watched the field go from like, I'm like, wow, it seems like psychedelics are just somehow meant to be very polarizing in a way. And there isn't really, it's a very extreme, right? So we go from like, this is a poison and makes a hole in your head to this is gonna heal your head, if anything, right? So it's
Mhm.
like, that's the narrative over the last few decades, and it looks like we're still going back and forth with that because I can see why And I think journalism and media has a lot to do with this. You could probably blame them for that than anybody else, because if you only want to put something in 8 words, and again, as someone come from tech, I've done marketing, I know how it works, but like nuance doesn't work. Nuance doesn't get attention, right? Everybody wants to know, like, does COVID vaccine help me from not getting COVID, or is this going to give me some new health indication, right? Like people just want to have a very direct answer, right? Nobody wants to know, oh, let me just take the vaccine and see what happens. Like nobody wants, people want to feel safe. Is this good or is this bad? And I'm here to say it's both. Like
Mm.
after 6 years, I'm just realizing that it's both, because it really depends on the who, the when, the how, the where, like so many different variables that we can never really say either everyone should do psychedelics or no one should do it. I can't even to this day really make that call between one or the other, right? So I think what I realized is that because the field doesn't listen enough to actually people who are going through these experiences, because we are not doing enough qualitative work and all we're doing is quantitative work, because the systems and the FDAs of the world and health councils of the world, that's what they care about, right? Qualitative is like, oh, nice, that's anecdote, right? Like they want to see quantitative work. So if that's all you're doing, well, then you're just looking at this very narrow lens of somebody's life that only you as the PhD understand, and the individual actually doesn't even think about their life in that way, right? Nobody tracks their life as in like, oh, I wonder if in the last 2 weeks, what percentage of my life have I been thinking about this thought? Like no single individual thinks about their life. So the whole model is fundamentally broken, because the model only works for the researchers and clinicians, for them to make sense of your experience. And it's a very narrow window to an individual's life.
So, how would you suggest redesigning things like either clinical spaces or research designs to be more patient centered in terms of drawing on that lived experience to come up with better protocols or designs or the elements of what you think would be better?
Follow the money, right? It starts with that, right? It's like who's getting paid in this field, right? And then you'll soon see, right? So like, because where the money is going is usually considered a must have, right? So you cannot have a clinic without a nurse and a psychiatrist, right? I don't know, you gotta like, so whatever that becomes a requirement, there's money and time and attention for it. And something that is not a requirement, then it becomes a nice to have. It's like a difference of a painkiller and a vitamin. Again, I'm using this analogy from the tech world because that's exactly how people build products, right? Like build the products that is a painkiller, not a vitamin, right? So because that's where the money goes. People are willing to pay for things that they know is painful, so they want to stop the pain. Businesses work the same way. Researchers work the same way. So until they really feel the pain, they're not going to put time and money on it, right? And but the thing is, the pain here, unlike the tech world, I can make a mistake there, but that's not somebody's necessarily real life, right? It's like a very tiny portion of their life they're using these tech solutions, whatever. In healthcare, that's somebody's entire life. Like even one case of harm is way too many, right? We're literally dealing with human beings with like thoughts and emotions, and they have just taken their psyche and handed it into you, and you did something to it, right? That the responsibility there and the impact on the human life, it can't be any higher. Like the stakes are high.
So,
And
you
when it
think
goes, yeah, then
we
it
need to
takes,
incentivize the systems, both again research systems, clinical systems, to be better accommodating of the patient's experience as they
yeah,
anticipate what they're going to go through and then what they actually
yeah.
go through.
Yeah, I mean, the MAPS case is a great example of that, right? What happened to the MDMA for PTSD. I think it's a perfect case study of what happens when you don't do this. Like those that are smart in the field hopefully can figure out and learn from that, right? But I wonder how many people are actually seeing that what went wrong is because they didn't talk enough to patients.
I think we're back
So,
online.
okay, great.
So, where were we? You were talking about, yeah, incentivizing clinicians, researchers to be better accommodating of the patient lived experience in the design of what they're building and executing.
Exactly. And I think it's one of those things, like I said, I've been thinking a lot about it. I've been talking to many people in the field around it. And what I'm realizing is that it's one of those things that needs to start from the top and trickle down, right? Because there's really two ways to make any change in life, right? So it's like this bottom up approach, sort of like grassroots, what I've been doing, let's say. but it's very limited, right? It's much harder to change a system from bottom up approach unless you have billions of dollars, but it's so much easier from a top down approach. And the top at this point is the health regulation agencies, right? So like FDA's Health Canada, TGA's in Australia, whatever, right? Because they are the ones that essentially they're the ones who are approving the trials, they're the ones approving the protocols, they're the ones saying like, you need the IRBs, you need ethical this, you need that, you need right. They can demand anything they want, and then the sponsors will find the money to do it because they know they just can't do it without, right? So if they say you need two therapists, they'll find money for that. If they say like in the case of MAPS trial, you have to build a separate room just for the participant to stay overnight and for some monitor to also stay overnight. Well, suddenly you have an extra 10,000 to do renovation inside your clinic, right? But the same clinic, you tell them like, why don't you pay a patient like $100 an hour to listen to that? Oh, we don't have money for that, right? So you see what I mean?
Yeah.
So it has to become a requirement the same way there is a requirement today that you need to have an ethical board or IRB to approve your consent form because they're supposed to make sure that the participants' rights are protected, right? We have understood that that's a requirement. So I want to see a world where this is also the same requirement. Meaning like, oh, great, you want to go do a clinical trial on PTSD? Fantastic. Show me. And again, I keep talking about this because this is how we do things in tech. Before I knew the word qualitative research, I used to call them user interviews.
Right.
I didn't even know the same thing. So I would like do Zoom calls with people, right? So let's say we're building something and I want to talk to 200 people who had that problem and they tried other ways to solve it. And then I want to know what worked, what didn't work, right? What made you stop? How much did you pay for it? All that before we even write a line of code, before we even think about what the solution could be, right? So why can't we have that in healthcare? Why couldn't Health Canada FDA say, oh, you want to develop something for PTSD? Well, first prove to me you have at least spoken to 200 PTSD patients and their caregivers and from various different diverse backgrounds, and you actually first of all understand the problem, right, before you're attempting to solve the solution.
Okay, that's a very interesting idea. It'd be nice to see that taken more seriously. And you're right, ultimately, I guess the money or the financial incentives or other types of incentives built to accommodate that. Much of the research is happening in the area of treating specific disorders with specific medications or medication-assisted therapies. But there's a long tradition of use of psychedelic plants, entheogenic plants, psychedelic substances, going back long before Western scientific medicine became interested. And then there's other types of uses beyond just the clinical uses, even contemporarily. What potential do you see for that in terms of patient lived experience, so the type of work you've been doing with lived experience, to broaden the horizon of the relatively narrow focus that medical research is currently focused on?
Yeah, actually, it is part of even what I want to do with this project too. Like, I started in this sort of very narrow clinical lens and legal lens. First of all, it was my own lived experience, right? It's what I know about. I was like, I'd rather talk about something I know than something I don't know. But I can already see that it needs to eventually, the circle needs to expand outside of that. Because even when you say that, like, again, now that I've spoken to enough people, even the ones that have done the experience legally, whether at a clinic, whether SAP in Canada, whether clinical trials, again, almost I can say, this is anonymized, I'm not saying anybody's name, that vast majority of them, 90% plus, have also had other personal experiences outside of that.
Mm.
So and now that I know that, we can't really, when we're talking about clinical legal experiences, you think that that only meant this person did that as part of treatment. But because you don't know, because we're not doing follow-ups, because we're not collecting other data, like I'm asking, I'm talking to them, but the sponsors are not doing that. And so nobody really knows what are they doing after. And again, I can say the pattern is that people do one experience that sort of opens them up to the possibilities, and because again, individuals don't like to track their life through their health indications. That's the clinicians like to do that. I'd be like, oh, here's my PTSD patient. Like, nobody who's struggling with PTSD likes to be called a PTSD patient for the rest of their lives. They like to be called, I'm a human being struggling. Whatever that means, right? You want to call it that, you go ahead and call it that because you believe in that system. But to me, I'm a human being struggling like every other human being, right? So because that's how people look at their lives, when they see potential around something, they're more likely to explore that. So let's say someone maybe tried ketamine as part of a clinic experience, and then they learned about psilocybin, and now they went to Oregon and Colorado, and they did a psilocybin experience, right? And then they did that, and then while they were in that group, somebody told them there's this other thing called ayahuasca, and then 6 months later, they went to Peru and they did ayahuasca. While they were there, somebody says, "Oh, but have you heard of ibogaine?" And then, this is a whole other thing. And then, like, they went to Mexico and they did ibogaine. And then while there, somebody says, "Oh, we also do 5-MeO." Like, I'm telling you, this is how it works for people. Like,
Mm.
some people actually, like, when I'm listening to them, they talk about it as if, like, they slowly went up. They're like, "Ooh, MDMA first gave me the courage I needed, like, da 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 da," when I was able to deal with my own stuff. And then when I was ready to deal with the world, then I went and did a mushroom experience. Sometimes you hear other way around, right? But people see it as like almost like progressions. They started with one experience that opened them up to the possibility, and then they got curious, and then they went. And so the whole, like, what is it? The borders, boundaries between clinical and non-clinical is actually very gray.
Do you mind if I ask, was that the case for you? You had an MDMA experience that opened your mind as a patient. Did you then become curious about other psychedelics and have other types of experiences?
Yeah, I have, but again, I'm actually very scared of psychedelics, and I'm just generally very scared of drugs in total, right? Like I said, I think it might even be a PTSD thing. It's just like because you get so attached to your current regular identity and sense of control. So anything that actually wants to take control away from you, I struggle with that. Right. So, some people may not have that, but for me, I'm very careful. I'm actually a lot more conservative, right? To this day, like I've been so curious about trying ayahuasca, like for the last maybe 10 years. I still haven't found the courage to do it, right? Because I'm just too scared of those sort of like very overwhelming experiences where I may not recognize myself, right? So yeah, I tried 5-MeO DMT, for example, and that was one of those experiences that I was like, oh wow, okay, like this is it's like I don't even know how to explain it compared to, let's say, the immunotherapy experience, but
Yeah, words don't quite capture it.
all right. So yeah, I would say this is definitely something that most people eventually, those that see a little bit of benefit, they go deeper. So that's why I want eventually with this initiative to also like expand that, and then especially bringing in caregivers. So it's not just the patients, right? Because if you're a caregiver or a patient, that's still a lived experience by itself. I'm very much interested in the lived experience of the professionals, especially medical professionals, those that have the guts to come out and talk about it, humanizing that, you could be a doctor and still be depressed. You could, be a therapist and still have PTSD, right? And so those are very interesting areas that I like to expand it to eventually.
Or research where the idea of objectivity, is actually relatively recent in the history of science. It's only the 19th century that became a principle that it was sort of adhered to more religiously. The idea of having lived experience for a researcher is still something that's, I think, that the field is struggling with, or at least public admission of lived experience by researchers that might be seen to taint their objectivity.
Yeah, yeah, I can see that too, right? And perhaps we need both. We need the groups that feel like this is needed, and then we need the groups that feel like this is not needed, and then we need to compare their results. I mean, that would be lovely, right? Even let's say with the experiential part of the trainings, right? Like almost everybody says like that's yeah, of course, if you're going to be a therapist, you need to have your own experiences, right? I mean, it's almost like no one can argue with that. And at the same time, yeah, you could also argue with that because if you have that experience, but you don't have a health indication, so let's say hopefully you're so healthy, you have no mental health challenges, right? And now you go to this psilocybin or whatever experience as part of your training. But how are you learning what psilocybin does for depression if you don't have depression? You're only learning what psilocybin does to a healthy individual, to someone with a job and career and a stable life and da da da, right? Publish papers, right? You know nothing about what psilocybin does to someone who was unhoused and is dealing with addictions and doesn't have a job and has been like in and out of like psych wards and like, so how psilocybin impacts these two people are very different.
Well, I think there's a principle of psychopharmacology of what's called idiosyncrasy, that every individual is going to have a different experience. There's no sort of universal experience that comes about from the ingestion of molecule A, B, or C. It's so much, setting, matrix, all these various factors, your cultural background. Yeah. So
It's good for them to have this sort of out of body experience or whatever. Like, just if you've never had that, it's definitely very useful for you to know that, wow, you could actually struggle with walking. You could struggle with going to the bathroom. Like, it's good for them to know that how vulnerable someone is going to be under these conditions, right? That is very useful information, which is why I'm still for it. That if somebody wants to do this, they better have that experience, because you better at least once experience in your life that, what it feels like to go to a bathroom under that. And if the bathroom is in the room or in the hallway, how does that feel?
Mm.
So it's useful for them to see that, but it's very narrow, right? So it's better than nothing, but it's definitely not. I would never be like, oh yeah, the fact that you did this, then now you definitely are someone that is safe to go to psychotherapy with, just because you took one mushroom session or one MDMA session in your 1 week long training, and definitely that qualifies you now to hold that space for others.
Well,
No, also wouldn't say that.
we've certainly seen that in the, for example, ayahuasca shamanism world, where people who've had a few brief experiences feel called to be serving the medicine without necessarily undertaking the kind of rigorous training that others in more traditional settings in Amazonian cultural traditions would be undertaking. So that's a
Yeah, I
great.
mean that's the downside of like giving too much power to lived experience, right? So I
Yeah, there's a balance.
recognize there is a balance there, right? So like you said, obviously like those shamans didn't go to school. Clearly they come from lived experience. And most of them, it's actually lived experience of mental health challenges. Like actually I was reading about this early in my immunotherapy trial experience, like 6 years ago, about like how those cultures view mental health challenges versus how West looks at mental health challenges. And those like more shamanic cultures, like actually somebody's going insane, whatever you want to call it, it's seen as a positive thing. For them is like, well, you're actually connecting to something beyond this world, like rather than pathologizing that. Again, this is, obviously not all of them, but but some of them will actually look at that as if like, oh, this person actually has the potential to become a shaman
Yeah,
because they've gone through some shit.
yeah. I think one of the sort of early scholars of shamanism, Mircea Eliade, talked about that sort of experience of having some kind of arduous mental challenge can be a calling towards that kind of practice. Have you heard
What
of
we call psychotic episode here, let's say.
sorry, say that again?
What we call psychotic episodes
Mm,
in the West, right? So somewhere else that might be looked at as actually this person has potential to help others
yeah.
because they've gone to the darkness.
Have you heard of a book called Crazy Like Us? By,
No.
I think the author's name is Ethan Waters. It's about how the Diagnostic and Statistical Manual of the American Psychiatric Association has been globalized, but that
Mhm.
the ways that mental illness are constructed through that Bible, as they call it, the Bible of psychiatrists and psychologists, is actually very culturally bounded, right? It's an artifact of the U.S. medical system, the sort of alliance of pharmaceutical industry and the HMOs come up with these very rigid types of definitions, but that the diversity of cultural experience around the world doesn't necessarily lend itself to the imposition. And so he goes through a bunch of examples where well-intentioned trained psychologists go to other cultures and find that they're not well prepared to deal with the kinds of manifestations of the diversity or plurality of mental pathologies. Again, I don't even know if that word
Yeah.
applies necessarily.
Yeah,
So,
and it's interesting when you look at the stats, right? So let's say like take PTSD as an example, right? Like look at like how many people in Netherlands have PTSD versus Canada versus like India. And then you would think like, as a percentage of the population. And then you would experience some other developing countries. You're like, man, I've been to some of those places. Like if anyone in the West lived in those places, like everyone would be called PTSD patient, right? Yeah, those people like living their lives. Nobody's walking around taking SSRI on a daily basis and calling themselves PTSD patients. So it's just like how we look at like what's the lens through which we're looking at. And then in the West, it's like, especially in Netherlands, I was shocked. They have the highest PTSD per population, I think, in all of Europe. And I was like, what? Like here's a country that looks perfect. Like everything looks like they got the money, they're smart, everything. And I was like, why is it that? Well, because it's through lens which you're looking at your population, right? Because even in Europe, they took the DSM, which is just a cluster of symptoms. That's all there is, right? And that makes sense because you need the symptoms to then sell drugs against, right? So, like, the only way that you can make sense of PTSD in a scalable way is that if you narrow down on nightmares, let's say, right? So once you define that, oh, PTSD means having nightmare, well, then now we can go and build a, sleeping pill or something to help with the nightmare situation, right? So they need to look at it through that lens because, like you said, it's all about how the pharma world works and how can you develop drugs for those, right? But if you just talk about PTSD as in this like super vague and very different for each individual and everything, which is the really truth of it, well, then how can you develop drugs and therapeutics for something that is like a moving target, right? You need to really narrow down on like, okay, it's sleep.
Yeah. Where do you see the field of psychedelic medicine and the influence of patient lived experience going forward in the coming years?
I mean, the good news is actually, as much as like I feel like I've been fighting for 6 years, I think we're actually at this earliest stages of seeing it tip over. Like I'm starting to see a lot more people talking about it. I'm starting to see like FDAs of the world talking about it. But I think, like we have to be careful that we're not again tokenizing it, right? I think that's very important. It's not just like, oh, we have this, oh, we have that. It's like really leading from that place. And that really honestly starts by the individuals that are making those decisions, the researchers, therapists, doctors, they themselves need to tap into their own lived experience a lot more, and then giving more attention to that than their, academic titles or what they read. And that's a good place to start. So I think the future we're going to go towards a way that perhaps this could be a new profession, right? Because to me, it's sort of like a Venn diagram of like you got the medical, right? You got the sort of therapeutical, and then you got the lived experience people, right? Because once they can work together, then is actually then I think the magic happens there, right? It's because I think we need all the expertise, we need all the stakeholders, right? Which is why when originally I launched this project, I thought it was be a lot more about giving voices to live the experience, just to realize actually the main thing I needed to do was to build bridges. I was like, okay, even if all the people with lived experience now have a voice, even if I put these videos on a homepage of a YouTube, that's still not going to really make an impact until people in decision making rooms offer a seat to these people. So until one day we have like a college of physicians for people with lived experience, right? Something like that. Like, so that way that we could formalize the training so that we could have some way of certification. So these are some of the things that I'm toying around with and thinking about. Hopefully with funding would be more achievable so that we could actually find a way. Be like, okay, what does lived experience as a profession look like, right? Maybe you could work in research, maybe you could work in education, you could work in practice, you could work in policy, right? Not everybody who had an experience wants to become a therapist themselves, right? Like I'm one of those people, I would be a terrible therapist. So that's why I didn't go that path, right? But somebody might want to go that path, right? So it would be nice for them to, like, if we could have this new profession that allows people to perhaps at times really turning their own pain into a sense of purpose. They'll be able, a lot of people struggle with jobs. They would be able to like maybe build a new career. I have many friends in that situation right now that they don't know what else to do with their lives. Well, this could actually give them a thing to do if they have a way to receive the education around it, having some sort of a license, honestly, as oversight, supervision, all the things we currently have for therapists and doctors. It'd be nice having this for these people. And then they could work in a clinic, they could work at a retreat center, they could work at the FDAs and Health Canadas of the world, they could work at pharma. Like my hope is that these people would be embedded pretty much everywhere because that's really the only way to get it right. If you only put them in one or two areas but not the rest, well then no, right? So the conferences need to be like that, the trainings need to be like that. So if you have a training program and all your faculties are a bunch of people with MDs and PhDs, like how good of a training is that, right? But once you balance that with half of them are people with lived experience who also now know how to talk about this, because it's not enough to have the experience, you have to actually know, right? Say if I want to become a lived experience person for PTSD, MDMA for therapy for PTSD, well, I need to actually learn about PTSD by
You need to
itself.
harness the experience and channel it in a way that's going to be
Yeah, you need
conducive.
both
Yeah.
experiential, but you also need real world knowledge.
Yeah.
So if you can provide that for those that want to stay behind, well, then they can take their experiential knowledge, they can learn how the system works, and then now they're actually equipped to work at the clinic or the pharma because now they know how to talk to doctors. Now they know what their boundaries are, what to say, what not to say, right? How to not lead into expectation bias and things like that. So that's the sort of the world that I'm hopeful about.
Well, thank you so much for the work you're doing. How can people learn more about your organization, about you?
So our website is called psychedelic-lived-experiences.com, and people can go learn more about it. We just ran a summit. We had 3,000 attendees from 74 countries, and it was incredible. So we have like 54 different interviews that people can watch and learn about this from people who have both personal and working experience in the field. And yeah, we look forward to finding more ways to bring that impact into actually something that could make a dent in the field, hopefully next year. So we're working on ideas to roll out.
Awesome. Well, thanks again. Thanks for taking the time to chat. And yeah,
My pleasure.
we'll be watching it. Awesome. Bye-bye.
Thanks, Ken. Bye.
The content in this podcast is for informational and educational purposes only. It is not intended to provide medical advice, diagnose, treat, or prevent any disease. Always consult a qualified healthcare professional before making decisions about your health or the use of any substances discussed here. Psychedelic substances remain illegal in many jurisdictions. Listeners and viewers are responsible for knowing and complying with the laws in their area. The views expressed by guests are their own and do not necessarily reflect those of the hosts or affiliated organizations. If you choose to explore these topics, please do so with caution, respect, and awareness.